Welcome to American Physician Institute for Advanced Professional Studies, Psychiatry Series, Volume 1, Issue 1. Over the next hour, we will discuss the antidepressant use in bipolar disorder, the good, the bad, and the unknown. Specifically, we will examine the efficacy and tolerability of antidepressants in acute bipolar depression, as well as efficacy and tolerability in prevention of bipolar depression. We will then summarize the benefits and risks of antidepressants use in bipolar disorder. Looking first at the efficacy of antidepressant use in acute bipolar depression. The average duration of an acute bipolar depressive episode untreated is about 3 to 6 months. Efficacy in the acute phase means improvement in that time frame. Most studies of acute bipolar depression are about 6 to 8 weeks in length. Longer studies have high placebo response rates due to natural recovery from acute depressive episode. In other words, the good news is that every acute bipolar depressive order goes away, usually relatively quickly. The bad news is that sometimes the episodes can be severe and suicidal, raising the question whether antidepressants can be beneficial in speeding recovery. In bipolar depression, most studies have been conducted in the acute phase. A recent meta-analysis summarized this literature. 15 randomized clinical trials had been conducted to date, a total sample of 2,373, but only 6 studies compared antidepressants to placebos, a total sample of 1,023. In those studies, there was a great deal of variability. Only 2 studies gave antidepressants to patients with proven mood stabilizers like lithium, valproate, or carbamazepine. Of the remaining 4 studies, 1 involved paroxetine, added to risperidone. 2 involved fluoxetine versus placebo, which, with lithium usage in 1/3 or less of patients, most patients received antidepressant monotherapy versus placebo alone, thus meaning no treatment. The final study, which comprised about half of all subjects in the meta-analysis, involved fluoxetine with olazapine versus olazapine with placebo. In other words, in the largest study, placebo means olazapine. This fact will be important in assessing the question of antidepressant-induced mania. A previous meta-analysis from 2004 had pulled these 4 studies, excluding the first 2 studies where antidepressants were used with mood stabilizers. The earlier meta-analysis concluded that antidepressants were more effective than placebo. In 2007, however, the largest study of this topic was conducted using standard mood stabilizers as baseline treatment. This study was part of the large NIMH-sponsored STEP-BD study, and it recruited 332 patients who were randomized to bupropion, paroxetine, or placebo added to standard mood stabilizers, lithium, valproate, or carbamazepine mainly. The STEP-BD study found that antidepressants were not effective compared to placebo, about 25% response for antidepressants and placebos. This is the largest and most definitive study of the topic, and it stands on its own as the best designed study to answer the question of antidepressant efficacy in acute bipolar depression. When added to the studies in the previous meta-analysis, this large negative study makes the over meta-analytic result also negative.